To all the panelists, we're starting the webinar now. Good morning, good evening, and good afternoon to all the participants. We're just going to wait 2 more minutes for everyone to join. Good afternoon, good morning, and good evening, everyone. We welcome you all, particularly those who are joining from far away or late or early times. Thank you for joining the WHO EPI-WIN webinar on collaborative surveillance for the current mpox public health emergency response. For those new to EPI-WIN, this is a WHO information network for epidemics and science and knowledge translations in health emergencies. So today we have a great panel ahead of us. Dr. Maria van Kerkhoff would be giving the welcome remarks. Dr. Anna Hoxha from the WHO Health Emergency Program. Dr. Marawi Aragwa. Dr. Michelle Mutuba. And also Dr. Keng Mercy as well. So our moderator today is Dr. Supriya from the EPI-WIN team as well. So just before we begin, some housekeeping. This webinar is being live streamed on the EPI-WIN YouTube channel. The webinar is being recorded, and the recording will be shared and available on our website and also shared with all the registrants. So interpretation is available today in French. If you'd like to select this, please go to the interpretation globe icon on your Zoom screen. So we invite you all to post your name, location, and organization in the chat box. We'd love to hear where you're joining us from, but please do add any questions you have to the Q&A box, not in the chat, so we can more easily keep track of them. So before we hand over to Maria to welcome this webinar, we'd like to ask you a quick Slido. And this is just, all our regulars will know, we love to hear your inputs. So I'll just request for the Slido to be shared. On the screen. Okay, yeah. So for everyone that's joining us, please do answer this question. Are you working on mpox surveillance? And it's very simple, yes, no, and partially. We'd love to hear from our audience. So we'll just give this maybe 1 to 2 minutes. Okay, so I think about 45% is no, it's quite actually evenly spread out. So that's great to hear from all the participants, and I'll hand it over to Maria to welcome this webinar. Over to you, Maria.
Thank you very much, and welcome everybody. My name is Maria Van Kerkhove. I'm the Interim Director of the Department of Epidemic and Pandemic Prevention and Preparedness at WHO. I sit at our headquarters level in Geneva. I'm also the Incident Manager for mpox at headquarters. So I'm very grateful that all of you have joined today, and thanks to the EPI-WIN team for arranging these series of seminars on mpox. The purpose of the webinar today is to share with the audience, with all of you, information about mpox collaborative surveillance activities to respond to the public health emergency of international concern, which was declared by our Director General, Dr. Tedros, a few weeks back. Since 2022, the World Health Organization, in collaboration with our member states, have established a global surveillance system for mpox. This system allows countries to monitor the outbreaks and inform response activities. It is very, very critical that we have strong surveillance because understanding of the circulation of mpox, understanding of the epidemiology and its transmission helps us to be much more precise in our prevention and our response activities. This global surveillance system has enabled us to monitor the multi-country outbreak and communicate reliable, timely information to all stakeholders. Since the declaration of what we call the public health emergency of international concern, WHO has strengthened mpox global surveillance efforts, especially in Africa, where we work in close collaboration with Africa's CDC and many partners, where we are actively monitoring the virus's spread in all countries. Collaborative surveillance involves working together to enhance disease monitoring by using strong existing public health and laboratory surveillance systems, and it means gathering information from various sources and advancing data analytics techniques. This approach helps us to better understand health hazards, risks, who is affected, who is at risk, as well as the circumstances that they live and work in. Today, our colleagues from WHO and the Africa CDC will share mpox surveillance technical information, discuss activities conducted by both organizations, and explain how we are supporting African member states in managing the surge of cases that led to the public health of emergency declaration. Accurate and timely reporting of mpox cases is critical to fight viruses such as mpox, and such reporting enables early detection, support of individuals and their families, and early detection of these outbreaks, helps us track the disease spread, allow for the implementation of effective control measures, and it guides our overall response activities. I encourage everyone to engage actively in these discussions. Please put your questions in the chat. Your participation is really key for enhancing the collaborative efforts. So together, and WHO works together with many, many partners around the world with all of you to support the response to mpox, and to safeguard public health. Back to you.
Thank you, Maria. I'll now hand over to Anna Hoxha from WHO to give the overview of the global mpox surveillance and diagnostics. Over to you, Anna.
Thank you. Oops, apologies. Thank you very much. I will kickstart the webinar and then hand over to my colleagues. As Maria mentioned, we are here today to talk about mpox collaborative surveillance and our activities since the declaration of the public health emergency of international concern. I will be giving an overview of global mpox surveillance and diagnostics, and then hand over to my colleagues from Africa CDC and the Regional Office for Africa. What is collaborative surveillance? As Maria already mentioned, the collaborative surveillance is an effort that we do to systematically strengthen the capacity and collaboration between different stakeholders working on disease surveillance, with a goal of enhancing public health intelligence and improving evidence for decision making. So we want to have better information, better data to make rapid decisions for interventions. We have three main critical objectives. The collaborative surveillance has been defined as part of the Health Emergency Preparedness and Response and Resilience Framework from WHO, with the objective of integrating national disease surveillance, threat and vulnerability surveillance to effectively diagnose and strengthen laboratory capacity for pathogen and genomic surveillance, and as a collaborative approach for the event detection, risk assessment, and response monitoring. With this objective in mind, in the current incident management support team, we have 3 pillars for collaborative surveillance, and those are epidemiology and surveillance, laboratory and diagnostics, and risk assessment and analytics. We'll go a little bit more in detail now of the activities that this collaborative surveillance cluster does in the current mpox response. Starting with indicator-based surveillance. The global indicator-based surveillance, as Maria mentioned, was set up in 2022 with the start of the multi-country outbreak, mainly outside of Africa at the time. And it is based on the mpox surveillance guidance, interim guidance, that you can see a screenshot on the right hand of the screen. This is a technical document where we provide definitions. What is an mpox case? What is a suspected, probable, confirmed case? How these cases should be treated, the measures to be taken, the contact tracing and monitoring. This surveillance that we set up 2 years ago now has 2 main components. One is the collection of aggregated number of cases by week and month by country. This comes to us through IHR communication and official national data sources. It is comprehensive and it aims to be timely. What does it mean? It means that we request member states to share with us as soon as possible when they have mpox cases to report them to us. The second component of this surveillance system is the case-based data. So additional to the total number of cases by week and month, we ask countries to share a minimum data set of variables for each case through a case reporting form. So this is a standard form that we have made available for member states so that we know and we understand a little bit better who is being affected from this disease, who they are, what are their characteristics. We are able to describe the outbreaks. This second system is not necessarily comprehensive, so not all the cases that are reported in the aggregated numbers we have case-based data for, and not all of it is timely, meaning it doesn't come maybe the same day or the same week of the notification. It could come a little bit later. Nevertheless, it has allowed us during the global outbreak to monitor quite well the global epidemic, and you can see a screenshot here. My colleague Michelle will show more later in details, but you can see the global epidemic curve since the start of the outbreak, where we were able through this system to monitor the outbreak, to understand who were the most affected groups, the risk factors they had, and also to be able to advise our response, but as well as that of member states and partners. So this is the main surveillance system that we have in place for mpox. It was set up already before. We have strengthened this surveillance system now with the declaration of the public health emergency of international concern, and we are trying to gather the more as timely as possible data with the 2 components, still the aggregated case and the case-based data for mpox cases in the countries. Additional to the indicator-based surveillance, we also have an mpox event-based surveillance. This event-based surveillance is a systematic screening of alerts from media and other sources that are related to mpox. This was also set up already 2 years ago. Depending on the phases of the outbreak, we have strengthened and also changed the objectives of this system. Currently, we focus the event-based surveillance on clade 1 monkeypox virus, especially the 1B. We look for new reported cases and deaths by countries. This is additional to our reporting from countries because sometimes the cases are reported through media before they reach maybe the official sources. We also look for a changing epidemiological situation. We look for unusual events. We look for implementation of public health and social measures, if there is any restriction that countries put in place because of the circulation of this virus, as well as we also screen for new epidemiological and modeling findings and publications, meaning what are other researchers doing there. We use in this system the WHO platform, Epidemic Intelligence from Open Sources, EPI-WIN. We screen it on a regular basis. We do share the results of this event-based surveillance with the incident management team every week. And you can see also from the bottom left of the slide that we have a classification of these signals, these alerts, if there's something we need to act upon, this is something we need just to monitor or to be aware of. And this complements the first indicator-based surveillance and sometimes can raise questions that therefore we go back to the countries and we ask for verification and validation of some of these signals if we haven't received the information yet. Another component of surveillance in the mpox response, but also more broadly, is the mpox community-based surveillance. The community-based surveillance is an approach that systematically allows to detect and to report events from the community by community members or community health workers. So if someone is not showing for healthcare in a facility, our indicator-based surveillance will not pick those cases. But if these are present in the community, in their households, and someone in the community noticed, they can report these cases through the referral pathways to access healthcare, therefore to be counted. This community-based surveillance aims to strengthen community members, community leaders, community health workers, community-based organizations that work in the area of healthcare. And also, it's an early warning system that allows us to detect cases and eventually to put in place control actions. In this area, we collaborate with partners such as IFRC as well as Africa CDC. I have reported here, for example, a definition for the community-based surveillance provided by Africa CDC. In the community-based surveillance, we tend to use quite broad definitions. We are not as specific as the indicator-based surveillance. For example, in this case would be any person with unexplained, recently appearing skin rash or swollen lymph nodes. So this is a very broad symptom that would need to be reported, and a healthcare worker will therefore conduct an assessment and decide if this person falls under the definition of suspected mpox case and if a testing is needed. We work with partners on this area. We try to empower community-based organizations that work on this and to provide technical guidance when needed and technical documents. One important area of development also during the COVID pandemic has been wastewater environmental surveillance. This is a component of surveillance that allows us also to monitor pathogens more broadly. So it involves sampling of sewage or human impacted environmental waters to see what pathogens are in these waters, so that to have a population level information. Is mpox, the monkeypox virus, circulating in a specific area? This system allows us, independently from the symptoms in the population or from the fact if someone is presenting for care or not, to early detect the presence of the virus in a population and to be able maybe to look for cases if we see that it is in wastewater. It can also allow to identify clades of the virus. We will go more into details in the clades of the monkeypox virus later, but we could just by screening the wastewater to see what clades are circulating, even if we do not pick it in the human population. It can therefore inform targeted public health action communication, and as well as testing. If we see that we have it in wastewater, it means that we might need to look better in human population. From the laboratory diagnostic point of view, the wastewater surveillance uses similar laboratory method. We will go into the lab a little bit later, and we aim through the mpox wastewater environmental surveillance and monitoring to leverage already existing systems. I mentioned already COVID-19, but also a very good wastewater surveillance system exists for polio. So in countries where these systems are already in place, we could just add one pathogen more and search it's present in this wastewater surveillance. At the moment, we are not recommending all countries to conduct wastewater surveillance for mpox. It requires some more research to be an established approach, especially in the quantifying, being able to quantify how many estimated cases in the population we have based on what is found in the wastewater. And the fact that sometimes we might not find the virus in the wastewater does not necessarily mean that there are no human cases. But if we find the virus in the wastewater, it is a signal that there might be human cases in the population. Another area of work is also collaborating with partners such as FAO and WOHA for a coordinated response at the human-animal interface. to monitor these infections. So we know that mpox is a zoonosis. Originally, it came from the animal kingdom, and it can spread from animals to humans. What we have observed in the last years is that there is an enhanced transmission among humans. Nevertheless, the animal to human transmission route still exists. The objective of monitoring animal infection is, of course, to prevent that the virus goes from animals to humans, but also that from humans it could go to animals. Reverse zoonosis, maybe when someone could infect a pet at home. The key actions for the animal infection monitoring is targeted surveillance and investigation of animal infection. This is especially when we know we have a documented exposure of our cases. The countries that are endemic for mpox are quite limited in number. They focus mainly in West and Central Africa. So not all countries have in place an animal infection monitoring. Nevertheless, we do advise countries to have an integrated approach where they monitor as well the reverse zoonosis. We do provide guidance in collaboration with the partners on how to prevent the spread, the interspecies spread, and also develop effective risk communication, community engagement approach where we advise communities how to behave to minimize the exposure of the virus through animal contact. And as well, also to promote cost-efficient diagnostic for animals. As some of you might know, those working especially on mpox, it has been very hard to isolate the virus in animal populations. Throughout these last years, because it's not clear how long these animals stay infectious or they carry the virus. They might be only for a limited period, and by the time we find a human case, the animal might not be infectious anymore. So we are not recommending countries to screen or to test all animals or all wild animals that have contact with humans, but only when there is a documented exposure to an mpox case. Going a little bit more into the laboratory component of the surveillance, on the right side of the slide, you can see that WHO provides technical guidance on diagnostic testing for monkeypox virus. Just as a reminder, the disease has changed the name from monkeypox to mpox in English, but the virus continues to be called monkeypox virus. At the moment, recommendation for testing, we recommend that all suspected and probable mpox cases are tested. The sample that is needed for test, the ideal sample is lesion material. It can be swabbed from the surface of the lesion. It can be the exudate, the fluid inside these lesions, or the crust. You can see from the image below how this sampling is done, where a trained healthcare worker with protective equipment, so the gloves, approaches the case. They will take a sample from the lesion, will either remove the roof of the lesion, will cut part of the lesion, will swab the lesion and put it in a tube, and this tube will be subsequently tested. Oropharyngeal swabs can also be tested for mpox, especially used for contacts when they start having some initial aspecific symptoms of mpox. If you are a known contact of an mpox case, and you start having a fever, you start having swollen lymph nodes, you might be tested through an oropharyngeal swab. Nevertheless, if finding the presence of the virus means that you have mpox, the absence of the virus in an oropharyngeal swab does not exclude that you might have mpox. Because this technique is not sensitive enough, and you might develop symptoms and lesions subsequently. Blood is not a recommended sample for testing of mpox because viremia, the virus in the blood, stays for a very short period of time, 24 to 48 hours after infection. Therefore, if your blood is tested afterwards, even when you have lesions, your blood might test negative. So as a repetition, the lesion material is the recommended sample for testing for mpox. When looking at the methodology to test the sample, so once you collected your sample from your patient, potentially the material from the lesions, then you need to do a PCR, real-time or conventional PCR. And what you are going to look for is the monkeypox virus. So you need to apply a protocol that looks for monkeypox virus. In alternative, you also could be looking for an orthopox virus in case if you have a monkeypox virus outbreak already declared, meaning in the area where you live, there is already a monkeypox virus ongoing. In that case, if you test positive for orthopox virus, it means that most likely you have mpox. These tests, as I mentioned, are the traditional PCRs, but it can also be the point of care testing through, again, PCR-based. The Gene Expert from Cepheid is a test that is able to do that. And these Gene Expert can detect orthopox virus, as mentioned before, in an outbreak already confirmed being a monkeypox virus outbreak. And it can also detect monkeypox virus clade 2. It is unable to detect at the moment the clade 1 monkeypox virus. Other point of care testing are also available, and some are under development. Antigen testing antigen RDTs, so rapid diagnostic tests for mpox, are available on the market, but at the moment they do not show sufficient accuracy to test, meaning that you might test with these antigen tests, this rapid test, but the results are not reliable at this point in time. Additionally, you could also have serology, meaning you could see if you seroconverted, if you produce immune response to fight the virus. But at the moment, these techniques are hard to set up. They need special lab protocols and reference laboratories with equipment and trained personnel. And since there is some cross-reactivity with our other orthopox virus that might be circulating, if you do not know this noise of these circulating orthopox viruses, it might not be able to tell if you really seroconverted because of mpox infection or not. Some of the activities that WHO is doing and supporting in the area of diagnostics is this emergency use listing that has been opened in order to evaluate in vitro diagnostic for mpox, so the producers can submit their products for emergency use listing, and WHO will evaluate them and grant them emergency use listing. There are also evaluation of these point of care testing and rapid antigens. This is done with other stakeholders such as FINE, but as well as academia. WHO provides global external quality assessment for mpox testing to countries, to member states, and partners that are in touch with us. WHO has opened also an access and allocation mechanism that includes vaccines, therapeutics, and a diagnostic test. So we will have a system with partners coordinated also with Africa CDC, where we will support countries to better allocate diagnostic based on their needs and the epidemiological evolution of the outbreak in the setting. The last area of support is genomic sequencing. So we are monitoring the spread of the monkeypox virus. As mentioned briefly previously, monkeypox virus has two clades, the clade 1 and the clade B. Each of them has two subclades, 1A and 1B, and 2A and 2B. We monitor closely where these clades are spreading currently. They have previously had historically some defined geographical regions, but currently they are quite mixed, especially driven by human-to-human transmission. We do make some of these isolates of these clades available through the WHO biohubs, where countries for non-commercial purposes can access the material for research. We also coordinate a functional characterization of the subclades. Currently, the clade 1B, it's ongoing to compare it with clade 1A and what actually changed in this virus, and to see some of the repercussions that this could have in the clinical manifestation, but also in transmission and the expansion of the outbreak. These were a few highlights of the activities the WHO is conducting in the area of collaborative surveillance. I think we can have a session of questions later. I will now hand over to my colleague from Africa CDC, Mercy.
Just before that, before we hand over to Mercy, just a quick question to all of you here, and I will share my slide again for Slido. So just a quick question, where do you get your information from on mpox, on prevention of mpox? If you go again to slido.com, #1341928, very quickly, we'd love to know where you get your information from. I see the CDC website and WHO webinar, that's great to know, ECDC, any other website, any other organization, Africa CDC, government, public, government agencies that are coming up, colleagues, any other sources, any other from the media, WHO and primary research, from the literature. Any more of you who get it from the media? You follow the media websites, whether it's you know, BBC, Al Jazeera, your local media,
Or social media.
or social media. Any of you get your information from social media? Okay, but just let it be for one more minute before we hand over to Mercy. This is great to know. LinkedIn, I see you do get from scientific papers, from EIOS, from ProMed, National Health System, official sources, Africa CDC. Great, thank you. I'll stop sharing my screen, but the slido.com is on the chat. So if you want to continue to input, please do so. I will leave this open. And over to Sidrish. To
Mercy.
To Mercy. Apologies. Mercy, the
Thank
floor
you
is
so
yours.
much. Yeah, thank you, Anna. Happy to hear that a number of us on the line are getting their information as well from Africa CDC. So as earlier introduced, I am Ken Mercy and I lead the Epidemic Intelligence Unit at Africa CDC. And I will be taking you through just a quick overview of what we do as Africa CDC in collaboration with other stakeholders in improving mpox surveillance on the continent. Next slide, kindly. So basically, these are some of the main surveillance focus that we have so far. However, before coming to this, I just want to mention that there has been a lot of collaboration, especially in terms of putting together what we call as a strategy, a continental strategy that we felt as a an institution could lead towards breaking the chain of transmission. One of these is, activating our EOC at a continental level and also setting up an incident management system that coordinates the response. In addition to that, we have worked with WHO and other partners to develop what we call a global joint continental response plan. And this continental response plan takes into consideration what my colleague Anna from WHO has shared initially. Focusing mainly on the surveillance pillar within that plan, we have a number of key initiatives and focus that we really want to work on. It includes actually focusing on improving surveillance early detection for mpox, and actually ensuring that it stays as a notifiable disease. Also leveraging several and multiple surveillance approaches towards improving detection for mpox, and this includes the event-based surveillance approach, community-based surveillance, that's community-based surveillance, focusing on case-based surveillance, as well as indicator-based surveillance in facilities. Also, not missing out on the point of entry, looking at it from the cross-border perspective to ensure that we have robust systems at our different points of entry to be able to detect and report cases promptly. And we're also looking at building capacity for accurate and timely diagnostics, and that will be seen in the next slide, as well as ensuring that we have a robust systems that is able to detect both clades, and also ensure that we have some sort of a One Health approach in our surveillance systems. And that's what we've been deploying both at country level and also at the continental level to ensure detection and information sharing across all sectors. Next slide, please. So focusing now on the surveillance, we have really we've noted that there's really been a gap in surveillance in so many countries. And one of the things that we really wanted to do was to ensure that we stay as that source of truth whereby you can be able to come to the website of Africa CDC and you're able to get very, very good information, accurate information around the disease. But how do we get to do this? Initially, for other outbreaks, we've been doing this as Africa CDC, publishing weekly bulletins and also daily updates, providing daily updates to member states and stakeholders. But this time around, we wanted to do it a little bit differently by publishing joint CTREBs together with WHO, just so that we have that single source of truth for the continent. And we are also able to, leverage our different strengths towards improving on these reports. Also, at Africa CDC, we have set up a dashboard which would go live next week, whereby you can also just go in there and you're able to see the distribution of these cases, as well as the deaths and what's happening in different countries. Currently, we have deployed experts that are also going in to support some sort of active case search in DRC, to be more specific, and also contact tracing. As you can see, the chart on the right hand panel of the screen, you'll see the proportion of cases that are actually of contacts as cases that had EPI linked with known cases. So as you can see, in a random sample of 144 confirmed cases, we could see that only 32% of all these cases were actually those with EPI links. That's the cases that actually stemmed out from contacts of known confirmed cases, meaning that we have 68% of these cases, out of the known transmission chain. And if you have these cases out of this transmission chain, they are the ones who definitely would continue to drive the spread of the disease in the communities and beyond. So we definitely need to ensure that we can be able to improve contact tracing. We are able to improve on early detection and also follow up contacts until they complete their 21 days. So we are actually calling for joint efforts to strengthen community-based surveillance, just like Anna mentioned, just so that we are able to keep track on all these contacts and also able to detect if eventually any become case. And we are also, we continue to join efforts with WHO to improve surveillance and data management, which is really one of the very critical issues that I might want to highlight on. So far on the continent, there's really a very huge gap in the way data is being managed, looking at it from standardization of case definitions to how the cases are being reported. So we've been having several meetings, especially with the colleagues in DRC, to ensure that we have some sort of standardized methodology of data collection, case classification, data flow analysis, and also interpretation of the data that is being collected. Next slide, kindly. So as Africa CDC, as you saw in the last slide, that in one of the slides that Anna mentioned, you would see that she presented some sort of a simplified case definition that could be used in the community. So this is actually coming from the mpox surveillance protocol that as Africa CDC will lead the process in developing. But just to also mention that this document was developed with support from other experts in European CDC, US CDC. They played a very key role in supporting the development of this document. And the reason why we developed this document is because of some of the gaps that I mentioned. There's really a gap in standardizing case definitions across board. While some countries still include confirmed case in their suspected case totals, discarded case in their suspected case totals, that is really not some of the standards that we really want to recommend at the continental level. So we've been able to put some of the standards, the standards that countries should kind of deploy towards ensuring that, we have some sort of accurate reporting, and also we are able to standardize the case reports across countries on the continent. So the protocol provides a comprehensive approach to enhancing the detection, monitoring, and response to mpox cases across member states. And it aims to improve data collection, analysis, data utilization, cross-border coordination to accelerate the outbreak response. And in addition, this protocol also provides a comprehensive set of variables for case-based and aggregate reporting of mpox. Remember that there's a lot of gaps in the line list that we were able to kind of analyze. across countries. And the reason is because different countries have different variables, but as we all know, based on some published literature, there are certain key variables that needs to be captured for us to be able to understand associations, as well as understand some of the risk factors that keep our population vulnerable to this disease, so that we can be able to also deploy targeted interventions across member states. But for this to happen, countries need to use a standardized mechanism of data collection and reporting. So we've also been able to set up timelines for reporting for both for countries that are non-endemic to the disease, as well as endemic countries, just to ensure that we have timely and accurate data sharing across board. Next slide, kindly. So focusing now on some of the key achievements that we've had so far, we started with South Africa just when they had the first week of reporting of some of the cases. We were able to train their national team. So they brought in stakeholders from the provincial, national epidemiological department, as well as surveillance officers from all 9 provinces. We also had experts from the Health Information System, as well as Border Management Authority. We also had participants from their Public Health Emergency Operating Center, as well as stakeholders from agriculture and environmental health. So we trained them using the One Health approach on event-based surveillance. And our team is going to be down there next week to also support them in developing their guideline. In Rwanda, we were also able to support them to finalize their event-based surveillance guideline, and that was launched just last week in collaboration. You see WHO as CDC country office also involved in this process. The reason why we think event-based surveillance still continues to play a very critical role, even in countries that are reporting or actively reporting cases, is because we definitely will be able to pick clusters of cases, as well as other pathogens or other diseases. Mind you, we could have an outbreak in an outbreak. I'll give you an example. When Uganda was reporting the Sudan Ebola virus, there was also a concurrent outbreak of, I think, Rift Valley fever that was ongoing. So we definitely need to ensure that countries don't miss out on other diseases while also focusing on mpox. So the event-based surveillance is really critical to us, ensuring the detection of not only disease-specific events, but also other known disease-specific events. Next slide, please. So moving now to our laboratory capacity, which still falls within the surveillance. You can't do good surveillance without good laboratory. We within the the Joint Continental Response Plan had set a target for our member states, and that target is getting countries to at least test 80% of all the samples from suspected cases. So that was kind of the target that we had set. Of course, we definitely will be moving the bar higher as we get progress within this outbreak. But you see that even with this 80% target, we still have 4 countries that were not able to meet up. And even for the countries that we see having a very high testing rate, you still see that their test positivity rate is still very low, showing that there could be gaps in clinical characterization of suspected cases, as well as maybe gaps in sample collection and shipment. Mind you, if you swap maybe a lesion when it is dried up, you run a risk of not being able to pick up the pathogen. So we definitely want to start encouraging countries to follow standard protocols for sample collection and shipment. And as you see in the next slide, we have been able to train. Next slide, please, kindly. Next slide, kindly. So, sorry, the slide before. Let me conclude, then I'll come back. So we have been able to train, we've conducted training in several countries, bringing together about 7 member states that have been affected to improve on their capacity to collect samples, as well as test for this disease. In addition, we have also provided sequencing equipment to member states, just so that they're also able to sequence. Our target so far for sequencing is 5%, ensuring that for all the samples that test positive, we are able to each country is able to at the bare minimum, test 5% of all the samples collected. So with this, we definitely need to also improve the capacity of our member states to be able to test these numbers. Next slide, please. So as we can see here, this just highlights the countries, the test positivity for each of the countries that I mentioned. So you see that we have CAR, we have Uganda, we have Liberia, Kenya, Nigeria, Gabon, Cameroon, Rwanda. You see their test positives really very low, below 20%. And this shows that, like I said, it's either our test, clinical characterization of the suspect, or it's not really giving us the good cases for the suspected cases. The precision is not that good, or it could be that we are not collecting the samples within the time that we should be able to pick the pathogen. Next slide, please. So like I earlier mentioned, in the laboratory space, we have been able to conduct a number of activities to improve. One of those is to train our lab experts on testing as well as sequencing. And we did this for 7 member states. We have also been able to procure, like I mentioned, our sequencing equipment, and we've delivered them to 7 member states. We've also been able to procure test kits that is capable of testing 28,000 samples for 18 member states, and the distribution is ongoing. And very, very excitingly is the publication of a list of molecular diagnostic kits. And the way we did this is, this was actually led by the Africa CDC Diagnostic Advisory Committee. So they met in Rwanda and were able to review current available literature and target a product profile of some of the diagnostics that were published by WHO as well. And they used a number of criteria to be able to arrive at those kits that are recommended. The first is the clade identification. The test should be able to identify clade 1 and 2, and the limit of detection should be at least 1,000 copies per milliliter. And also there shouldn't be any cross-reactivity with other known mpox viruses. And also the test should have had a regulatory approval or at least an emergency use listing. Just like our colleague from WHO said, they are actually opening up for those companies to manufacturers to submit their kits for emergency listing. And we actually be working with the WHO emergency listing list to be able to also update the mpox molecular diagnostic test list as needed. Next slide, please. Thank you.
Okay, thank you so much, Mercy. I'll now hand it over to our colleague, Michelle. The floor is yours, Michelle.
Thank you very much, Supriya, and good afternoon to everyone. So I said, my name is Michel Muteba, and I work for the WHO Regional Office for Africa, based in the Nairobi Hub of Emergencies. And I'm now just going, after you have listened to my 2 sisters, you are going now to get to the numbers, because I'm sure that you want to know what are the countries that are affected, what has been happening in terms of the number of people who have been affected, and where, and in terms of time, just to give you some information. So let me just give you the global overview of the situation. So the mpox situation since 2022 has been Sorry for that. Yes, I just want to say that since 2022, we have 123 countries actually that have been affected with mpox, and they've reported over 100,000 laboratory confirmed cases, and unfortunately 234 of them have passed on. And just this year, we have 70 countries that have reported at least one case of mpox, and the cumulative number of lab confirmed cases that have been reported this year is 11,095. And this actually including 50 related deaths. So on your right-hand side of your screen, you can see that while in the other regions, in the other continent, we have the number of new mpox cases decreasing monthly, but in the African region, but also in the Western Pacific region, we see the numbers that are increasing. So on the next slide, I just want to show you now what we have in terms of profile or the different characteristics of the mpox confirmed cases. On the left, you can see that for the other regions except the African region, it's affecting in majority the males. But when you look at the African region, we have seen that it's the proportion of males and females who are affected is quite balanced. And we have also seen that it's affecting more the range of age or the range of those who are between 30 to 39 years old, among the cases that have been reported to WHO. And the main type of transmission has been recorded as a sexual encounter. And of course, there were some cases for countries that are still reporting individual-based data to WHO. We have, for those who were confirmed to be positive for mpox, at least 87% of them who were men who have sex with men, and close to 50% of them are persons who are living with HIV. But we still have a proportion which is just below 3% of healthcare workers who are also affected, which also gives you insight on what is happening in the healthcare facilities where we go in terms of measures that needs to be taken for infection prevention and control. And just less than 20% of them have a history of travel. And again, as I said, 94% of all that were confirmed positive and the data reported to WHO have confirmed to have a history of sexual transmission. And only 10% of them are hospitalized. So on the next slide, I want now just to give you, but I won't go in details to, because Dr. Anna has already spoken to you about the distribution of clades. But here you just need to see on the map that this new one, which is, in the news now, the clade 1B, which was detected in the DRC at the end of 2023, it's slowly spreading to other countries. And you can see it has been detected in not only Africa, in the eastern part of Africa, but also in Europe and also in Asia. But we have other clades, as she said. We have the clade 1, which is usually found as in the central part of Africa, clade 1A. But just I want to mention here a bit about the history of mpox. The first human case was found in 1970 in the DRC. But this mpox virus was first detected in 1958 in a laboratory of monkeys in Denmark. So since then, as you know, the viruses, they usually mutate and they evolve. And that's why we can see what is happening. But also just to tell you that this mpox virus is definitely in the same family as the smallpox, which was eradicated before the 1980s. So you need to have that in mind just to understand that what we are facing for the moment, it's probably not something new, but we can really when we get the information on time, receiving data from countries, we are able to put in place the right measures so that we can stop this, and we believe that we can also eradicate this mpox virus. Let's just go to the next slide. So the next one, I've spoken about the mutation. So I just want to focus, the next slide, please. I just want to focus on the African region because it's the region that is for the moment reporting over 90% of the current cases of mpox. So since January this year, we want to tell you that 14 countries plus Morocco, actually I have to say 15 countries in the African continent have reported at least one laboratory confirmed case of mpox. And we have actually 15 countries that are active because Morocco has reported a new case just two weeks ago. And in total, we have 9 countries that have reported at least one case in the past 2 weeks. So you can see that this virus is still making its way, and we are mounting up the response to make sure that we can contain it as soon as possible. And just in EPI week, which ended on the 22nd of September, which was Sunday, 172 confirmed cases were reported to WHO. And of course, the data is incomplete because we still need to receive data from countries such as the DRC. That is usually 1 week late because we want to compile the data weekly. But when we go at the global level, you can have access to a dashboard with cases, which is usually updated monthly. But for the African region, we just make sure that we update this data weekly. And at country level, they just make sure that they update the data daily. So what we also want to tell you when we compare, the week that ended on the 15th of September to the previous week, we observed a 67% increase in the number of new cases, laboratory confirmed cases that were reported to WHO. And DRC and Burundi, just for those two, account for over 95% of all the cases that have been reported in the last week. Again, as I said, we have this case that was reported in Morocco. And beside that, we have cases of clade 1B, one that was reported in Asia, India, with a history of travel to Dubai. Let's go to the next slide. So on this one, as I said, we have seen since the end of 2023 when we started observing this clade 1B, which really raised concern. We have seen that the number of new cases were increasing and continue to increase. As we ramp up, the surveillance, we are receiving more data because we are improving on that side together with Africa DCD and other partners. We are able to provide and show you this information. So this year only, up to the 22nd of September, in the region, we have received 6,580 notification of lab confirmed cases, and out of these, 32 were dead. But these are, as we said, we are not showing you the number of those who were the suspected cases, but on the next slide, I'm going to show you that. But here, I just want to tell you that out of all these countries that have reported cases this year, we have actually accounted for at least, in terms of comparing these cases to last year, it's 6 times more cases than those that were reported for the whole of 2023. The next slide. So in terms of suspected cases, we have recorded over 31,000 cases across the region since the beginning of this year. And out of these, 844 were recorded as dead. And this gives us a case fatality ratio of 2.7%. And I know many people will ask the question why we have different numbers that we're reporting. And sometimes when you go on the report, because the data is changing daily, and we have different partners, so you need to take that into account, that we are reporting sometimes using different data. But I'm happy that my colleague, Mercy, said that we are trying to make sure that countries align themselves so that we have a good frequency of reporting and have numbers that can inform everyone so that no one is confused. But when we look at all these suspected cases, unfortunately, as she said, not all of them are getting samples and are getting sampled and getting tested. So in terms of the positivity rate, it's really below 55% in the region. Let's go to the next slide. So we are aware that we have many cases that are still suspected that needs to be tested. And we see how to mount, as I said, the interventions in the field. But on this slide, what we want just to show you that we have different narratives when it comes to the distribution of mpox cases on our continent. We have the clade 1A, where we have countries in the Central Africa, including, of course, the DRC, Cameroon, where we have seen also the number of cases that are increasing. And this type of mpox clade 1A has been endemic in these countries. And then we have the most recent, which is the clade 1B, which was observed, as I said, in the South Kivu at the end of 2023, has also seen, a rapid spread to neighboring countries and, of course, overseas. And we have also the clade 2, which I think you are aware was the main cause of the outbreak, the global outbreak that we had in 2022. And in Africa, it's mainly found, in the west, the western part of the continent. So we have DRC, Burundi, Uganda, Kenya, Rwanda, but Sweden, and also Thailand, that have been reported clade 1B mpox cases. Let's go to the next slide. So as I said, in the DRC, just to focus on the DRC, and I'll probably also go to Burundi because these two countries account for more than 95% of the cases that are reported. We have, as I said, a good number of suspected cases that have been reported in the last 4 weeks before the end, before the 15th of September. And you can see that over 25 or 26,000 suspected cases, including 5,600 lab-confirmed cases have been reported, and a huge number of suspected deaths. But unfortunately, because sometimes they are not tested, and then it's a bit difficult to conduct post-mortem analysis to ascertain those deaths that they are linked to mpox. But we still do surveillance on that, and to make sure that even the number of suspected cases, even the deaths, it has to decrease when we look at the mortality rate weekly. So just the DRC has reported close to 1,800 suspected cases in the week that ended on the 15th of September. Including 258 suspected deaths. So they have 5 provinces that are the highest in terms of the burden of cases. The South Kivu, Sankuru, Equateur, the Sud, Ubangi, and Chopo. Let's go to the next slide so that you can see in terms of the epi curve. Let's go to the next slide. So these are the epi curves of the countries that are the most affected in the DRC. And as I said, you can see in the Sud Kivu, that's where we went. I think there was a good team of WHO from Geneva, together with a team from AFO that went there and went up to the South Kivu to see actually what was happening. And that's where we were able to determine that there was really a history of sexual encounters that was linked to this clade 1B. Let's go to the next slide. In terms of testing and positivity rate, again, this is in the southern part, I think in the eastern part of the DRC, in the North Kivu, which was just affected after the South Kivu. We have seen that children are significantly less likely to test positive than adults. So which means that this outbreak or this transmission is more among the adult, and confirming again the assumption that we had about the sexual transmission. Let's go to the next slide. And I know many people have this question because everywhere in all the platforms when we present, they always ask, why do we have so many deaths in the DRC? While for this same clade 1B outbreak in countries such as Rwanda, Uganda, even Kenya. They have not recorded any deaths. Even in Burundi, where they have a lot of cases that they're reporting weekly. So when we look at this graph, you can see that the case fatality ratio is definitely higher among suspected cases, but this is now in the endemic regions. And when we compare them to what we have in the South Kivu and the North Kivu, which are mostly affected by the clade 1B outbreak, we can see that the case fatality ratio is very low when it's linked to clade 1B. And of course, I know Africa CDC with partners are preparing to conduct a mortality audit investigations on that. And even WHO has finalized the transmission of mpox protocol, where we are going to investigate so that we can have more details on what exactly is happening, especially in the DRC, but also in other countries. So there are a lot of research, operational research that are on the way. Let's go to the next slide. So here it's again just to show the difference as times goes on, the weeks are passing during this year, comparing the incidence rates per age group. We have seen that among the confirmed cases, there is just a little variation when it comes to the age groups that are the most affected in the new cases that are reported. But when we look at the suspected cases, we can see that there is a huge variation in terms of the incidence rates. It's really increasing even in the children. So there is a lot that needs to be done. So I think even in terms of testing, they also have to focus on the children. We can move to the next slides. We can talk a bit about Burundi. So in Burundi, as you have, they've declared this outbreak on the 25th of July, 2024. So just in 8 weeks, you can see that the increase was phenomenal. So it was really exponential. Up to now, they have 707 lab confirmed cases. They have not reported deaths, thanks to God. And 29 out of the 49 districts are affected. And just in the last 4 weeks, they have reported 465 cases, but they are facing a lot of challenges in terms of, curbing this community transmission because of logistics. But all the partners, WHO and Africa CDC, are coming together so that we have human resources and finances sent just to support the country so we can control this outbreak. The next, I think this is probably my last slide. Go to the next one. Yes, that was my last slide. And I just want to tell you, if you have more questions, I think all the data on the mpox is available on a dashboard provided by WHO, but we're also going to have one provided by Africa CDC. And we are going to converge in terms of providing the right numbers to all those who are interested to know exactly what is happening around mpox, where it's happening, and who are the most affected people. Thank you very much. Over to you, Supriya.
Thank you very much for that very comprehensive overview. Now we come to the most exciting part after the wonderful presentations. This is the Q&A session. And we have a number of questions here, which is great. So thank you to all the participants for showing the interest. Anna here has been really rapidly typing, trying to answer your questions as fast as possible. But let me pick up a few questions from the many that we have here. Okay, one is, we have quite a few on diagnostics. So we have one is from Jean-Viviel Momboli, saying how reliable would ELISA testing of IgM to assess recent community exposures to mpox? Are there any reliable lateral flow antibody RDT? So Anna, would you like to take that?
I think we have our colleague Lorenzo from the diagnostic lab team. Lorenzo.
Okay, over to Lorenzo.
If you're talking, Lorenzo, we do not hear you. You might be muted. Okay, maybe let's give Lorenzo a few minutes and we come back to that question.
Okay, then another question right after that is from Alejandra Acevedo. Hello, thanks for the webinar. I have a question. Is the dry lesion torula still the ideal specimen, or can it be in viral transport medium? Would you like to answer that,
I
Anna?
think this would also be for Lorenzo, but
Okay.
among our recommended samples, the dry roof of the lesion can still be ideal for testing in appropriate media, transported in media, and that it can still be tested for mpox if that is the only lesion available. Otherwise, we always recommend to sample at least 2 lesions, preferably into different stages of the disease. But if the crust, the dry crust, is the only one left, that could also be used for testing.
Thanks, Anna. Okay, while we wait for Lorenzo, another question this time to Mercy is from Ashok Besnet. And he says, with presented information by Mercy on the low positivity despite high testing rate and more cases with no epi lineage, is it the right time to revise criteria of suspected cases or rethink our testing criteria? I'd put this both to Mercy, since he referred to her, and to Anna, and also...
I will let Mercy go first. Over to you, Mercy.
Thank you so much. And I think that's a very good question. And one of the things that we are trying to evaluate is how many of these countries that are reporting are actually using the standard definition for suspected cases. That would be the first question to start with, because definitely if we are not using the standard definition, you run a risk of making your case definition for suspected case very, very broad in such a way that it picks even known cases that don't have any characteristics of, or possibility of even becoming a case of an mpox case. So the first thing is let countries first of all standardize standardize their definitions and actually get to use the standard case definitions. And the second thing I also want to flag here is that for instance, DRC that accounts for say 80 or 85 and more of the total cases reported on the continent. We have zones that are very, very hard to reach zones. So samples may be collected, but end up not getting to the laboratory. We were kind of doing a kind of retrospective kind of evaluation on why. I give an example: Burundi did not get to 100% of testing, and when we reached out to the laboratory, the laboratory, all the cases, all the samples that the laboratory received, they actually did, test for those samples. But the gap was not with the laboratory, but with there are so many different other processes that needs to happen before the laboratory gets a sample. So we're able to see that there are other gaps from the field to the laboratory that needs to be fixed. And I think that's another issue of us trying to fix, ensuring that we have good transportation for samples, shipment, even the media in which it's been transported. The cold chain is also very important to also look at, and that also would impact on the testing quality. Over to you, Anna.
Thanks, Mercy. Maybe what I can add only is that we do have a comprehensive case definition that includes the main signs and symptoms of mpox. And nevertheless, the signs and symptoms tend sometimes to be quite similar to other eruptive skin diseases, especially maybe in children, and they could be misclassified, meaning that it's an eruptive skin disease, it seems to have some lesion, it's similar to mpox, therefore a healthcare worker would need to take a sample and test. At the moment, we do not think that the official case definitions that we recommend need to be changed based on the observation, because we think they are quite inclusive to include all presentations of described mpox. But as Mercy also said, the use that is done of these definitions at different levels varies, and we might not have full visibility or full control of that, and trying to harmonize and standardize is the utmost priority, more than changing the official definitions. Over.
Thanks. And Michelle, would you like to add anything there as well?
I think Mercy and Anna have made justice to that. Thank you.
Thank you. Lorenzo, are you ready to speak? There are a number of questions on your area of diagnostics.
Maybe he can address them in the chat.
Okay, maybe he can address them in the chat. Okay. Another question, is there, what proportion of cases are clade 1B?
This is a very, very good question. I think we need to be aware that sequencing at all levels in many countries, it's not very high, so not a high proportion of overall cases are sequenced at the moment, although we might be recommending 5 to 10% of cases to be sequenced, those with travel history, those that have an unknown source of infection. The current capacity does not allow for a high proportion of the samples to be sequenced. What we know is that this clade 1B started in Eastern DRC. We know currently it circulates in South Kivu, in North Kivu, in DRC, and in Kinshasa. We know it has been found in the country's eastern border of DRC, Rwanda, Burundi, Kenya, and Uganda, and a few cases exported externally. If we take all these cases together, we are probably below the 4,000 cases of this clade 1B, and when we put it in perspective, it's a small proportion of the cases reported at global level, but also in the African continent. Nevertheless, it's the highest increasing among the two subclades 1A and 1B. So we do have 1A circulating in all other provinces that were previously endemic for mpox in DRC. We do have it in neighboring countries, and to our knowledge, these areas continue to report 1A. But first limitation, as mentioned, the sequencing capacity is suboptimal, and what we assume, it's because in those areas predominantly it's what we have seen. Nevertheless, some areas might be underreported and underrepresented. I can also hand over to Mercy if she wants to argue give more on this. Thanks.
No, I think you really captured everything so far, and really nothing to add. Yeah.
Thank you, Anna, and thank you, Mercy. We have a couple of questions on children. So the first is from Emma Kingham, who says, what is the sensitivity and specificity of PCR testing in children? And the second by Jean Mukadim, who says, at which age of children is mpox most dangerous? There's been a lot of concern about mpox in children, so perhaps you could explain a bit more on that.
I can maybe start. If colleagues want to chip in, please feel free. What we can say is that as far as we know, in historically affected areas in DRC, especially, but also in some neighboring countries, children have been the most affected for among the cases that are reported. There have been more children that were cases of mpox. The narrative has been that older people, they were immunized because they were previously vaccinated with mpox, and through their life they were exposed to the virus. Therefore, there was some built-up immunity through the age groups. Nevertheless, this is not the case everywhere in all African countries. There are areas in African countries that have never been exposed to mpox, where all the population is potentially susceptible, or at least those that have not been vaccinated against smallpox. In endemic areas of DRC, among cases, children are still the biggest proportion of reported. In newly affected areas, especially in the Kivus, in South Kivu and North Kivu, where we have the clade 1B circulating, the outbreak started involving mainly adults initially, but as the outbreak expanded and it entered households, we have now also children reported among the cases, because it's spreading through different modes of transmission in households, in close contacts, in families, but also in the community. So we do have children also presenting mpox. About the characteristics of the case, of the test, I don't think it depends mainly on being an adult or a child test per se. the test would maybe make a difference based on the prevalence of the incidence of the disease for a specific group, but I will also hand over to Lorenzo for comments specifically to the test. About the manifestation of the disease, I think we can say that children are more prone to have eruptive skin diseases than maybe adults. And some of these diseases could be measles, could be chickenpox, could be rubella. So among children might be maybe easier to confuse mpox with other diseases, since these other diseases might be more present. Nevertheless, in some of these settings where mpox is endemic, healthcare workers are very used to see mpox, and they can, in some instances, very clearly distinguish what is measles and what is mpox. We do not want to give the wrong message now that all measles is misclassified as mpox and the other way around, because some of these healthcare workers, they can really see the difference. There might be some cases that present very few lesions, very few or very minimal, or in different stages, especially if you see maybe the lesions towards the end, there might be more easy to be confused, or where they are at the start. I hope that was clear. Very long answers. I hope it was helpful. Over.
Thanks, Anna. Would any of the other speakers like to add anything to that? Mercy and Michelle?
Okay, let me add just one thing. And just like Anna has said, there are so many different modes of transmission. And we also have realized or have seen that, at the beginning of grade 1, when the first case was reported, the mode of transmission that was actually the narrative was more or less sexual transmission. But I think that is what we are trying to kind of change that narrative, because in as much as we are seeing more children being exposed and being affected in the proportion of children that have been affected in the population that has been affected in DRC are more or less children, like they have a higher proportion. But if we move to Burundi, where that is reporting same clade 1B as South Kivu, you're not going to see that same proportion amongst children. There's the shift in the age group that's affected in Burundi. That just shows us that even though clade 1B, we know that the new route that was not known before is sexually transmitted, it could be transmitted sexual contact. We still have to put the narrative right that mpox can be transmitted through close contact. There are several different contacts. Sexual contact is just one of the contacts, because most of these children get infected by their parents who maybe contracted it and then came back home and became very close to the kids, and they could get it. And some could also get it at school. So I think that's also something that we need to change. Then the second thing is also around the profile of these children that are affected. There's really need for countries to really report on, good case-based data, so that we are able to also understand what is the nutrition profile of all these children, so that we are also able to also, get those associations to see those that actually were severe and those that had maybe just passive infection. So it's important for us to have that kind of granular information to be able to do some sort of good detailed analytics to be able to tell you who are these children that are most vulnerable to this disease. Over.
Thank you, Mercy, for that, and very important as well.
An
Michelle?
addition from my side,
Want to
yes. Yes, I just wanted to ask that we have to understand actually how this mpox virus is transmitted. And, when someone has the symptoms, usually, they're going to be in the palms of the hands, but also sometimes they also find them in the mouth. So it has also been found in different fluids. So we understand that when we have these possible ways of contaminating, others, or transmitting the virus to others through contact, it's not just going to be by sexual contact. But we are also trying our best, to study the chains of transmission, and that's why we are always engaging through risk communication and community engagement with communities and all those who are affected, so that they can provide the right information on the contact that they have. We have to list them, and then we have to monitor them over a certain period of time to see if they're going to develop any of the symptoms of mpox. But unfortunately, one of the challenges that we also find in the field is we do not always receive much information on the contact of those who are confirmed positive. But we are hoping that through RCC activities, this can be improved. And that's why we also count on the community of those who are participating to this webinar so that they can also go back and educate, in the various communities, the importance of sharing information with the healthcare workers. Thank you, and over.
Thank you very much, Michelle. A very important point as well, getting information on the context to give the whole context, see the whole picture. And thank you for highlighting the importance of the role of all those who participate in the webinar, and they can go forward, take the message forward to the communities and to all they work for. And on that note, I think we should come to a conclusion today because we are well over time. But thank you very much, first of all, to all three speakers for a fantastic presentation, very comprehensive, with very important points being raised here. As you can see from the number of questions, just keep increasing and they don't stop, which shows how important it is. Thank you, as always, to all the participants. You make EPI-WIN what it is. So please send in your questions. Tell us what you do with this information. Tell us what you would like from us. Please write to us. Tell us how you use this information and what difference it's making, because we want to make a difference and we want to reach out to everyone we can across the world. And finally, a huge thank you to everyone behind the scenes, to the interpreters, to our IT support here, to Project Echo, who's been helping us behind the scenes. But last but definitely not least, I'd like to say a big thank you to Sadrish Pradhan, who's been working, for those of you who followed EPI-WIN, who's been working on EPI-WIN for the last 6 months. Today, I think, is her last EPI-WIN, and she's leaving us soon. And she's made a huge difference from sending all your presentations to you, to setting up the webinar. She's played a critical role in this. And so a huge thank you to Sadrish. I hope you have great memories of EPI-WIN as you go forward with your life. Thank you very much. I'd also like to thank Maria for her support, and Nedret, who's not here today, but who's been supporting EPI-WIN, and Olivia, who's, I don't know if he's still there, but he's also critical in this area. Thank you very much, and goodbye. So the next, save the date, our next October is a very busy month for EPI-WIN. We have 2 EPI-WINs a week. We start off with a country experience on 3rd October about how to prepare for non-infectious disease emergencies, how to prepare your hospitals, how to build capacity in countries, the lessons from Moldova as the war in Ukraine was taking place, what they did. Then we have understanding and implementing MERS-CoV investigation protocols. And finally, very relevant for this time is Health Meets Peace, WHO's Global Health and Peace Initiative, coming up in the next 2 weeks. So hope to see you then. Bye.